I'm going to talk about metallurgy and implants, specifically as they relate to biomechanics as best as I could. The topic and breadth of this is kind of ridiculous, so I tried to pare it down as much as possible to some clinically relevant stuff and include a little bit of basic science here at the beginning. So just a quick review in terms of types of metal and why we're using them. It's mostly related to their Young's modulus as well as their working ability in vivo and relative biocompatibility. So stainless steel and cobalt are generally going to be much stiffer compared to bone, and titanium is as well, but it's a little bit closer. And then PEEK is about as close as we're going to get to bone in terms of a Young's modulus, but has obviously some more difficult working properties in terms of brittleness and workability. Here's a little bit more detailed of a chart if anyone wants to go back and look at it at any point. But we're all working towards things that are going to be strong, stable, and workable, but also allow us to kind of mirror the properties of bone as best as possible. So in terms of some advancements for rods and screws, this is a study out of the Spine Journal looking at rod stiffness as it compares between 6.0 Ti, 5.5 cobalt, and then a pre-machined bent rod that was not notched in the process. So in their study, unsurprisingly, cobalt was stiffer than Ti, and that kind of mirrors what we'd expect with the Young's modulus. But they also noted that the notch-free cobalt chrome rods were significantly greater ultimate load compared to conventionally bent rods. This one's kind of a nod to Dr. Mundis and the 100 notches that I put to every rod I try and bend for him. So sorry about that. In terms of pedicle screws, this is
no worries.
Yeah. Thanks, Dr. Mundis.
You won't be around when they fail.
Right, exactly.
Just kidding.
This is a pretty old study, but looking at pedicle screw depth and how important it is in terms of the strength of the screw. They used a human cadaveric model and measured failure in terms of pull-out and flexion and torsion load. They compared ipsilateral, or I guess contralateral pedicles in a single vertebrae to kind of standardize the bone density and quality of the cadaveric specimens, and they put the pedicle screws either at 50% and 80% or at 80% and 100%, and measured the failure strength and torsion and flexion loads. And they found that if you only got to 50%, your screw is only about 75% as strong as getting to 80%. And then screws that got to 100% or bicortical had about 125 to 150% the strength of a 80% depth screw. And then you can see that just 5 more millimeters sometimes will get you as much as 26% increase in strength. So really important to try and maximize your screw depth. Obviously with the caveat that 101% sometimes is a pretty dangerous thing to do. So trying to get at least 80% depth is kind of what they advised based on safety as well as strength. Looking at thoracolumbar fractures, this is a study looking at whether or not including the fractured vertebral level is important biomechanically in terms of your construct. This is a group of 80 patients that had thoracolumbar fractures treated in a randomized trial, which is always kind of impressive in any kind of trauma setting. They were either fixed at one level above and below, skipping the fractured level, or including the fracture level. They had about 40 patients in each group. Clinically, they showed very similar outcomes in terms of patient-reported outcomes and clinical outcomes. However, the instrumentation failure rate in terms of broken screws or change in kyphosis was much higher in the bridging group. And the bridging group had about 29% worsening kyphosis, whereas the including group, or the group that instrumented the fractured vertebrae, had about 6% decrease in kyphosis. And they noted that this was only really problematic in C-type fractures. So if they controlled for Mogrel type fracture, they actually found that it really was only the C-type fractures that this was clinically significant with their construct. Another kind of add-on to this study out of biomedical engineering in 2017 used a computer model to kind of look at this in a little bit more in-depth analysis. So they looked at models of T11 to L4, and they used 4 different setups in terms of their fixation points, either 1 above and 1 below, or 2 above and 2 below, and then plus or minus instrumenting the fractured vertebral segments. And they used computer modeling to see which constructs were the stiffest, and also what adding that fractured level instrumentation did in terms of construct stiffness. Unsurprisingly, long segments are stiffer than short segments, which I don't think we need a computer model to tell. But what was interesting is in their short segment constructs, they found that the fractured vertebrae inclusion was a significant increase in the stiffness. However, in their long segment constructs, the addition of a pedicle screw at the fractured level did not really show a statistically significant difference in terms of the overall stiffness of the construct. Looking at other ways to kind of advantageously improve pedicle screws, there's been a lot of talk about pedicle screw augmentation, specifically cement in the form of polymethyl methacrylate. So this is a lit review in the Spine Journal from 2015, looking at kind of every article they could come across, looking at cement and other kind of ceramic or calcium-based methods of improving fixation with pedicle screws. From their lit review, they kind of broadly stated that PMMA is effective in terms of improving pedicle screw fixation for osteoporotic and revision models. They tried to go into depth about fenestration versus kyphoplasty, or preloading the screw tracks with the cement rather than putting it through the screws. But they found that the pre-filling method was similar in terms of effectiveness to the fenestration method in their review. However, when you get a review this size, a lot of heterogeneity is going to exist across the study models. They did show that in cadaveric models that you were able to remove these screws. It did cause significant extraction torque, which is kind of unsurprising, but they didn't find any studies that demonstrated catastrophic damage to the vertebral body with removal. They, of course, note that the biomechanical tests were generally performed at inopportune times in terms of determining the ultimate success of the technique, as most of them were tested either at implantation or after only a very brief amount of cyclic loading. And you'd expect, if you're going to have some difficulty with these things, it's the long-term cyclic loading and stress on stress that's actually going to cause some kind of problem with their PMMA construct. But they did note also that the other non-PMMA studies, such as the bioactive calcium ceramics, are probably being unfairly discriminated against by these study types, as they would hope to demonstrate some kind of on-growth or osteointegration, and that would make them better than these studies of mostly cadaveric or early implantation testing would tend to show. A more recent study looking at PMMAs is from Clinical Orthopedics 2 years ago now, I guess. Wow, it's 2022. This was a retrospective study looking at osteoporotic patients. They had 240 patients that they had pedicle screw fixation, and they divided them into patients that they did augment and patients that they didn't augment. And then of the augmented patients, they were subdivided by how the screws were augmented, either with solid screw augmentation, just filling the pedicle track, or using fenestrated screws. And then they looked at the incidence of loosening, and then between the two major groups, and then within the cement augmentation groups looked at leakage, screw loosening, and fractures as kind of secondary outcomes in their study. In this group, the screw loosening was 50% in group 1, that's the unaugmented group, and then only 7.3% in the augmented group, and that was statistically significant. Among the group that was augmented, they found that cement leakage was about the same in both groups, slightly higher in the fenestrated group, but not clinically significantly so. And they did find that screw loosening was a little bit worse in the pedicle screw track augmentation group versus fenestration, which was clinically significant in this group. Pretty small numbers there, but able to reach significance. And then they did note an increase in screw fracture in the fenestration group as compared to the pedicle track augmentation group. However, this was not clinically significant, but that makes sense. If you're going to fenestrate your screws, you're going to have to put holes in them, and holes in your screws would, in my mind, tend to promote a risk, at least, of increased fracture of the screw. Some notes about surface treatments, and this is kind of a little bit over my head in terms of the science behind all this stuff, but the general idea is going to be taking a material that we already use and making it better, more bioactive, or more biocompatible by applying some type of treatment to it without grossly altering the structure or the function of the metal or the material in question. So this is a study that was looking at grip lasting and also acid etching as it applies to pedicle screws, and they also looked at standard like orthopedic cortical screws. In this study, they used mini pigs as their model and evaluated whether the screws showed a difference in pull-out strength, stripping torque, and then they also used micro CT as well as histologic analysis to assess the bony on-growth and kind of improved integration qualities after these methods of treating pedicle screws. So like I said, there were 3 groups. There were smooth pedicle screws, just standard available screws. Those same screws were then sandblasted, and then they performed what they call SLA affinity, which I'm sure is a brand name, but is large grip blasting followed by acid etching. And then they compared the groups at 1 and 3 months after implantation. And in their study, they showed at 1 and 3 months, both the micro CT as well as the histologic analysis of the bone in question was improved with the SLA affinity, and the sandblasted was superior to the standard commercial screws. They showed removal torque and pull-out strength were also higher at 1 and 3 months, and that the quality of the bone around the screws were improved with the SLA affinity, showing mostly mineralized matrix as opposed to just regular matrix tissue around the screws. This is a study out of Nanomedicine, which I think is a sweet journal title, but this is looking at anodizing your metal as a way of improving the bioactivity and surface properties of the metal. And anodizing is effectively using the properties of metal as a conductor to change the surface qualities. In this case, they were using fluorhydric and acetic acid, as well as a current to create nanopores in the titanium. And they tried multiple different nanopore structural sizes to see which one was going to be the most beneficial in terms of promoting on-growth and the correct osteoblastic gene differentiation within their study population. So they made 20, 30, and 50 nanometer pores with their process, and then looked at how those rods responded in terms of their osseous by implanting these metal implants into a rat tibias for 1 to 3 weeks. And they found that the nanostructure treated titanium rods showed significantly accelerated bone apposition as well as bonding strength, both in vivo and in prior in vitro study results. So same metal, but just small, really small changes can make a significant difference in terms of how fast bone adheres to it and the actual cell types that are being generated near these rods. Another way that they're looking to improve strength of apposition is with hydroxyapatite coating. This is a pretty common thing that's seen in other branches of orthopedics. Most commonly, at least for me, was in external fixator pins. But this is a study looking at pedicle screw treatment with hydroxyapatite. A very small sample size, only 7 patients, but they had pedicle screws treated with hydroxyapatite, and then of those patients, half of them had their screws removed about 1 to 2 years later. They found that the insertion torque was actually higher, which I wouldn't think, except for that maybe the layer of hydroxyapatite makes the screw a little bit more or a little bit higher diameter than it otherwise would be. It was about 25% or 33% higher in terms of the insertion torque, but importantly, the extraction torque for the hydroxyapatite coated screws was greater than their torque wrench could measure, over 600 newtons, while the conventional screws they generally found were loose. So their conclusions were, yeah, that hydroxyapatite is going to increase your purchase of your pedicle screws, but they were looking at future study designs of maybe not coating the entire pedicle screws, only selectively coating parts of the pedicle screw to prevent this insanely high extraction torque, as they were worried that they were going to have screw fracture or vertebral body fracture from the fully coated pedicle screws. So maybe some more research to be done there. And then this is looking at a surface treatment property or a surface treatment protocol for PEEK. So taking the same ideas that we've been applying to titanium and looking at PEEK in this study, this is from Applied Materials. They looked at plasma surface alterations of the PEEK as a way of changing its surface chemical properties without spraying on some kind of additional layer. And their hopes were to kind of obviate a little bit of the concerns about delamination as the material itself is being modified rather than having a second coating applied to it. So they use plasma immersion ion implantation. No follow-up questions on what that means, but it's basically a treatment for the PEEK. And then they used a rat model and implanted this treated PEEK into the rats, and then at about 8 weeks, sacrificed the rats and looked at them both histologically and biomechanically. And they noted that the new bone formation with these treated PEEK samples were enhanced, and this was true especially even 1 and 2 weeks after surgery. And they noted that the quality of this bone actually was superior, not just the quantity, and that the bone itself was actually more highly mineralized already, even at 2 weeks, which is pretty impressive given the normal integration time period you'd expect for for a PEEK implant. And then quickly, I'm going to go through some other constructs and other kind of things for a little bit of historical perspective, but also things that I came across I thought were interesting. This is a comparison of the available biomechanical cages from 2001. And this is, before I ever knew what an ACDF was, but the designs of these things are pretty wild. And when you compare them to what we're using currently, this was a sheep model study that looked at 10 different implants and kind of biomechanically tested them in all planes of motion. And you can see each of the implants there on the right. They used basically the more popular implants at the time. And they found that even with these widely different appearing implants, as well as different methods for insertion and immobilization, that the design of the implant didn't have too much of an effect on their biomechanical testing, with some specific kind of caveats. These screw-based models, like you can see in C and D here, if they had 2 screws implanted instead of 1, then they weren't any different than the cylinder design groups or the cage design groups. But a single screw did actually behave much more poorly in their testing. And they noted that the cylinder designs had a better extension and bending stiffness as compared to the other types of cage designs. But overall, they found that it wasn't of great importance, the difference between all these cages, which are wildly different in terms of their design and their properties, which I thought was pretty cool, given, you know, kind of the homogeneity of what cages look like nowadays. A more modern look at ACDF implants. This was a study of Kody Barrett model looking at integrated fixation versus plate fixation. So they had specimens that started out intact, and they did a discectomy and put in a standalone implant there with 3 integrated screws. And then they removed those integrated screws and instead attached this standard kind of 4-hole plate to the front. And then they would remove the 4-hole plate, and they did testing on if the cage was just left in there without any fixation. So they noted that there was a statistically significant change in the range of motion of the constructs between the plate and the standalone constructs. But they did note, unsurprisingly, that some fixation, either the standalone construct or the plate construct, were both significantly improved in terms of their limiting range of motion as compared to just the implant alone. So fixation does matter, but in their study, it didn't matter whether it was a standalone fixation or plate-assisted fixation. Briefly about cervical discs, and this, you can kind of have an entire talk about the biomechanics of cervical discs and what they're trying to accomplish and the kind of changing landscape in that regard. But this is a really good article out of 2020 Lit Review, and kind of biomechanical concepts about current cervical disc arthroplasty technology. You know, the goal of these disc arthroplasties is to mirror as much as possible normal biomechanics of the disc space, and to allow the remainder of the soft tissues and cervical spine to behave as normal. So they note that each implant can have up to 6 possible degrees of freedom with rotation and translation in the 3 orthogonal axes. And then they further looked at these implants, broke them down by how many components they had or how they were designed. Just quickly, here's the 3-component discs, and this is the Simplify, the Mobi C, and the Secure C. These kind of function with anchored plates on either side, and then a free or semi-free mobile bearing in the middle. This is as compared to a 2-component disc. A few more of those, including the Pro Disc, which is the kind of more common one that I've heard of this group. Same idea as the 3-component constructs, except for in these instances, the bearing surface is attached to either the superior or inferior end plate, losing one of your degrees of freedom in terms of implant interfaces, but you get a more kind of controlled implant bearing surface connection. And then the non-articulating discs, or the discs that rely on some kind of deformable surface in the middle of them. It's the Bryan disc, the M6, which I think is the most popular of this group, and then those other 2 there. And overall, they kind of go through the biomechanics of all of them and how the different degrees of freedom allow for the instantaneous and overall center of rotation to change as a result of translation and degrees of freedom of movement. But they basically came to the conclusion that if you're going to attempt to reconstruct a mobile level, the closest we're ever going to get is a 6 degree of freedom disc prosthesis that's going to allow all of the normal planes of motion to occur through the disc, and thus kind of limit the effect that the disc replacement is going to have on the remainder of the anatomy. They also said if you're looking at a hypermobile segment, the kind of prevailing thoughts at this point is to use a disc with some type of built-in resistance to angular and translational motion, as this will kind of limit the hypermobility that you leave in the construct. Briefly on lumbar discs, this was just a look at the biomechanics of a lumbar disc model in fresh frozen cadaveric spines. They looked at contact pressures and peak pressures of the facet joints at both the instrumented level, in this case was L3-4, and the level above. They noted that axial rotation had the greatest effect on contact pressures, and overall that the facet joints at the level of instrumentation saw greater loads kind of across the board. However, the adjacent or the super adjacent level showed actually an unloading in general in terms of the loads at the facet joints. So kind of doing what we would expect or what we would hope that it would do in terms of offloading the super adjacent level and maybe preventing some adjacent segment breakdown. And then TLIFs, I know we try not to bring up that word here, but just briefly, this is a look at the biomechanical comparisons between different shapes and different positionings of TLIF cages. So this was again a cadaveric study looking at 20 levels of L2-3 and 20 levels of L4-5. They were tested doing a unilateral TLIF. They used those 3 cages that you see there, the kidney shaped, the articulating, and the straight bullet cage. And each cage was placed in the kind of 2 main anatomic positions that each of those cages are described, either central or anterior, and then central or lateral for the bullet cage. And they looked at deformation curves and range of motion limitations and loading for each of these cages. Overall, they found each cage and each position had a decrease in the slope for their load displacement, or it effectively immobilized the segment, but that there was no statistically significant difference between any of the cages or any of the cage placements, which is kind of a good thing, I think, because that means that as long as you're getting the cage in there, it's doing its job in terms of adding rigidity to your construct. Fusion and clinical outcomes not kind of withstanding in a cadaveric model. And then wouldn't be a SDSF presentation without nods to the lateral. So this is a study out of Spine in 2017 looking at biomechanical analysis of adding on a lateral to an already fused segment. In this case, it was a 2-level TLIF model. And then they looked at loading it in terms of non-destructive flexion extension, bending and torsion. So they started out with intact models and they did a 2-level TLIF from 3 to 5 on all the specimens. And then they added a lateral at L2-3 above their previous fusion. And then in addition to that, they sequentially added either a supplemental lateral plate, a spinous process plate, and then cortical or pedicle screws across that segment. And then the final construct for every specimen was a 3-level TLIF, and they kind of set that to be the gold standard in terms of what they were comparing against. And what they found was just adding the interbody device adjacent to the fusion was a significant reduction in all motion planes. They noted that the addition of the lateral plate was even more restrictive in terms of lateral bending and torsion. The spinous process plate was restrictive in flexion and extension. And then overall, the addition of pedicle screws with the lateral cage was comparable to their traditional 3-level TLIF. And so kind of, even though it's a hybrid construct with TLIF and lateral, that it was equivalent to doing just a full 3-level TLIF in this case. So a good option for adjacent segment disease and biomechanically strong as if you'd just done the 3-level from the beginning. So overall, kind of run through the various interbody types and what we're attempting to do in terms of modifications to standard pedicle screws and rods, but biomechanics, especially for spine implants, I have found 20 articles on finite element analysis for a single ACDF level. So it can kind of get into the weeds pretty quick, but hopefully it kind of gave you guys an overview there. So.
That's great.
Great talk. Yeah, really good. Big topic, like you said. Hey, did you run across anything with that had like the antibiotic coating on pedicle screws?
No, I saw things about it, but I kind of figured I didn't want to get too far down the antibiotic rabbit hole. I didn't see a specific biomechanical testing about applying that to the screws and whether or not it changed their biomechanical properties. But yeah, that'd be super interesting because any kind of
what were you thinking, Greg? Were you thinking there was a study on it or just theory?
Yeah, I think there's some studies on it. I just asking him for his insight if he'd read about it.
No, I didn't in terms of the biomechanics, no. But
there's some thought that screw loosening.
It'd be incredibly hard to study.
Some thought that screw loosening is also associated with like P. acnes and things like that, versus just non-union.
My guess is if there are studies on that, most of them would be of the cadaveric or insertion torque kind of study to make sure that you're not delaminating or having problems with the coating. It'd be so hard to study infected cases because like how many antibiotic coated pedicle screws are out there to be removed? And
I think that
Greg's point is about loosening. Yeah,
that's what I mean. That would be so hard to study.
Why? No, it wouldn't be that hard. You'd have to do CTs on everybody. We actually entertained this concept of studying screws for infection, but the infections are so rare,
right? Unless
you study, diabetic trauma patients that are undergoing tumor resection. But in our patient population, that's smoke. It's so rare that the patient population you have to study to be in the many thousands. Yeah. But if you're to Greg's point, if you look at loosening, which is considerably higher in its prevalence, you might be able to pick up enough delta that you don't have to have an insane number of subjects. On the other hand, one thing we've kind of learned from our own internal studies is we don't have that much screw loosening when there's a solid fusion. And so I'm not so sure that it really is infection or this colonization. My bet is we just don't get fusion fast enough. And that's why we incredibly small prevalence of screw.
Yeah, I agree with that. I agree with that. I think, like even in our, in the, like say the modulus study, that provides so much absolute stability right off the bat that we just don't see much from the side of, implant loosening. So I think you're right on that. But awesome. Well, we're a little past time, But any other comments, questions from the group? All right.
No, great job.
Great job, Kody. And yeah, let's